Hey everyone, and welcome to The Deep Dive.
where we delve deep into all those medical topics you need to know.
You got it? I'm Harvey.
And I'm Donna.
We're both MCCQE reviewers.
And we know just how tough that exam can be.
Yeah, so we're here to break down all those major concepts.
Using super reliable sources like stat pearls.
And today we're tackling cardiovascular disease.
Oh, yeah, get ready. This one's a biggie.
But real quick before we jump in, a disclaimer,
Yeah, this is just for educational purpose.
not medical advice. So
Always consult a qualified healthcare provider.
Right, always. All right, so let's kick things off with atherosclerosis.
Ah, the silent killer.
Right. It's actually responsible for like 50% of deaths in Western societies.
It's crazy. And did you know it all starts with those fatty streaks way back in childhood?
Really? In childhood?
Yeah, they might seem harmless at the time.
But they're the first step in a process that can lead to.
Heart attack, strokes.
Oh, wow.
Yeah, it's all about how these fatty streaks gradually develop into fibrous plaques.
Fibrous plaques.
Yeah, think of them like hardened deposits on the artery walls,
Uh-huh.
and eventually they turn into these vulnerable plaques.
So what makes those vulnerable plaques so dangerous?
Well, they're like ticking time bombs just waiting to rupture.
Okay, so why are they so prone to rupturing?
It's all about what's happening beneath the surface. They contain cholesterol, inflammatory cells, and other debris.
So basically a buildup of gunk,
Yeah, and as it accumulates, it weakens the plaque's outer layer.
making it more likely to rupture.
Exactly. And inflammation plays a huge role in this whole process, too.
Inflammation, how so?
It's like a fire smoldering beneath the surface, weakening the plaque even further.
So it's not just about the size of the plaque, but also its stability.
Right, and how inflamed it is.
Okay, that makes sense. So how do we know if someone has atherosclerosis before it gets to that critical point?
Well, we start with the basics.
Like a lipid profile,
Exactly, to measure those cholesterol levels.
with actually LDL, the bad cholesterol.
Yeah, and of course we check blood pressure, too.
Makes sense. High blood pressure puts stress on the arteries.
Right, making them more vulnerable to damage.
What about other more specialized tests like HSCRP?
Ah, good one. HSCRP stands for high sensitivity C-reactive protein.
Okay.
It's a marker of inflammation in the body.
So it can tell us that there's inflammation even if we can't see it.
Exactly like a smoke alarm signaling there might be a fire somewhere.
I like that analogy. So it helps us assess a patient's overall cardiovascular risk.
Precisely. And depending on the patient and their risk factors, we might also use imaging.
Like an abdominal ultrasound.
Yeah, to check for aneurysms.
What about peripheral artery disease?
We might use the ankle brachial index for that.
So it's like a detective's toolkit using different tests to gather clues.
Exactly. And if we need a closer look at the heart itself, we can use an ECG.
To measure the heart's electrical activity.
Right, and detect signs of a previous heart attack or current ischemia.
What about that calcium score test I've heard about?
Ah, yes. The calcium score uses a CT scan to measure calcium in the coronary arteries.
And calcium buildup is a sign of plaque.
Exactly. So
Yep.
the higher the score, the more extensive the atherosclerosis.
So we can get a pretty comprehensive picture of what's happening in the cardiovascular system with all these tests.
We can. But thinking about those med students gearing up for the MCCQE,
What are the key takeaways they should remember about atherosclerosis for the exam?
well, I think the most important thing is to understand the pathophysiology.
How those fatty streaks develop.
Right, the role of inflammation,
Yeah.
what makes plaques vulnerable.
Knowing the risk factors is key too, right?
Absolutely. That's where prevention and treatment begin.
And it's not just about memorizing a list, it's about understanding why they're important.
Exactly. For instance, high LDL cholesterol isn't just a random number.
Right, it's about those LDL particles infiltrating the artery wall.
And triggering that inflammatory cascade.
And of course, knowing the different diagnostic tests is essential too.
Absolutely, what they tell us and when to use them.
So we've laid the groundwork for atherosclerosis,
Mm-hmm.
but this condition can lead to serious consequences.
Oh yeah, like acute coronary syndrome.
Right, ACS. That's where things get really intense.
It does. But before we dive into that dramatic world.
Maybe we should take a quick breather and recap what we've learned so far.
Yeah, good idea. It's a lot to take in.
Okay, so just to recap, atherosclerosis is a chronic disease that starts early with those fatty streaks.
Right. It's all about plaque buildup in the arteries and inflammation making them vulnerable.
We have a range of diagnostic tests to help us identify it and assess its severity.
From basic lipid profiles and blood pressure checks to more advanced imaging techniques.
The big takeaway for the MCCQE is understanding the pathophysiology, knowing those risk factors, and being familiar with the diagnostic tools.
Exactly. Now, with that refresher, let's move on to acute coronary syndrome, or ACS.
All right, bring on the drama.
This is where things get serious.
So what exactly is ACS? How is it different from stable coronary artery disease?
ACS is an umbrella term for several conditions, including STEMI and STEMI and unstable angina.
And the key difference is that ACS is always symptomatic.
Always unlike stable coronary artery disease.
So if a patient comes in complaining of chest pain, that's a red flag for ACS.
It could be chest pain is a classic symptom. It's
Well,
not always that straightforward, especially in women diabetics and older patients.
They might have different symptoms.
They might experience shortness of breath, lightheadedness, jaw or arm pain.
Nausea, sweating even.
Exactly. So ACS can mimic other conditions.
That's tricky. How do we make sure we don't miss it?
That's why a thorough history and physical exam are so crucial.
We need to really listen to the patient.
And consider their risk factors. Perform a careful exam to rule out other causes.
So it's like being a medical detective, piecing together all the clues.
Exactly. And time is of the essence with ACS.
The American Heart Association says an ECG should be done within 10 minutes of arrival.
Absolutely, every minute counts.
Because what's happening during ACS is a sudden decrease in blood flow to the heart muscle.
Right, usually caused by the rupture of a vulnerable plaque,
Oh, wow.
leading to a blood clot that blocks the coronary artery.
Like that volcano erupting.
Yeah, but this time it's causing a major traffic jam in a coronary artery.
And that can have devastating consequences.
It can, leading to ischemia, a lack of oxygen.
And potentially infarction, the death of heart tissue.
You got it.
That's terrifying.
So what's the treatment for ACS? What do we do when someone comes in with suspected ACS?
The initial approach is similar for all types. We start with immediate measures like aspirin,
To prevent further clotting.
heparin to thin the blood, antiplatelet therapy to reduce platelet stickiness.
Pain control oxygen if they're having trouble breathing.
It's all about stabilizing the patient and preventing further damage.
So the treatment then diverges depending on the type of ACS.
It does. Tell me about STEMI versus NSTEMI.
Okay, so STEMI stands for,
ST elevation myocardial infarction.
it's the most severe form of ACS.
diagnosed by specific changes on the ECG, those telltale ST elevations.
Like flashing red lights signaling a major blockage. Exactly. In a STEMI, the blockage usually involves the full thickness of the artery wall
Completely interrupting blood flow.
to a large portion of the heart muscle.
So time is muscle with STEMI.
Absolutely. The longer the artery remains blocked, the more damage occurs.
The gold standard treatment is PCI, right?
Percutaneous coronary intervention. You got it.
Where they open up the blocked artery with a balloon.
Then often place a stent to keep it open.
And PCI should happen within 90 minutes of arrival at the hospital.
Ideally, yes.
What if PCI isn't an option?
Then we turn to thrombolytic therapy.
Clot-busting medication.
Right. These medications can dissolve the clot and restore blood flow.
But they also carry a higher risk of bleeding.
They do.
Okay, so STEMI is all about speed restoring blood flow. ASCPI. What about NSTEMI and unstable angina?
They don't show those characteristic ST elevations on the ECG.
But they still represent a serious decrease in blood flow to the heart muscle.
Yes. The treatment approach is a bit more nuanced.
How so?
We'll start with symptom control and stabilization, using medications to relieve pain and improve blood flow.
And then?
We'll decide on the timing of catheterization based on the individual patient's risk factors and presentation.
So it's a more individualized approach.
Exactly.
And regardless of the type of ACS, long-term medications are crucial for preventing future events.
Absolutely. We're talking about beta blockers, statins, ACE inhibitors.
And for some patients with extensive coronary artery disease, we might consider surgery.
Like coronary artery bypass grafting or CBG.
So much to consider.
There is.
To recap for our listeners studying for the MCCQE, the key points about ACS are that it's always symptomatic and time is of the essence.
Absolutely. Recognizing the different presentations is crucial.
Both typical and atypical.
Understanding the ECG changes that differentiate STEMI from NSTEMI.
And knowing the treatment algorithms for each condition.
All essential for the exam.
Okay, so we've tackled atherosclerosis and the drama of ACS. Now let's shift gears a bit and talk about renal artery stenosis.
Ah, yes, RAS. This one can fly under the radar.
It's a sneaky consequence of atherosclerosis.
It is renal artery stenosis, or RAS, is the narrowing of one or both of the arteries that supply blood to the kidneys.
And atherosclerosis is one of the main culprits.
It is.
So it's like a domino effect, one problem leading to another.
Exactly. But how does a narrowed renal artery cause trouble?
What are the consequences?
Well, for starters, it's a major cause of hypertension.
High blood pressure.
You got it.
Yeah.
In fact, it's estimated that RAS is responsible for hypertension in 1% to 10% of people with high blood pressure in the U.S.
Wow, that's a significant number.
It is. So we're talking about a condition linked to atherosclerosis that also contributes to a major health problem.
But why does a narrowed renal artery lead to high blood pressure?
It all boils down to the kidney's role in regulating blood pressure. When the renal artery is narrowed, blood flow to the kidney is restricted.
And that triggers.
The release of renin,
Renin.
an enzyme that sets off a cascade of events leading to the production of angiotensin II and aldosterone,
Angiotensin the second.
is a powerful vasoconstrictor, meaning it narrows blood vessels throughout the body.
And aldosterone causes.
The kidneys to retain sodium and water.
So vasoconstriction plus fluid retention equals high blood pressure.
Exactly. It's a chain reaction. A narrowed artery leads to a hormonal cascade that raises blood pressure.
And there's another mechanism too, right?
There is. When blood flow to the kidney drops below a certain level, it disrupts filtration in the glomeruli.
The tiny filtering units in the kidney.
Right. This can lead to chronic kidney damage over time.
So RAS is a double whammy, potentially causing both high blood pressure and chronic kidney disease.
It is.
What clues might make us suspect RAS in a patient?
Sudden or resistant hypertension, especially in younger patients, is a big red flag.
So if someone's blood pressure suddenly spikes or it's hard to control with medication,
We need to consider RAS.
it's like a puzzle.
Yeah.
We need to be on the lookout for those subtle hints.
Exactly.
So let's say we suspect RAS. What tests do we use to diagnose it?
We start with lab tests to assess kidney function.
Like BU and creatinine levels.
Electrolytes urinalysis.
Okay, and for imaging, how do we actually visualize the renal arteries?
There are several options, each with its pros and cons. Duplex ultrasound uses sound waves to create images of the arteries and assess blood flow.
Okay.
We also have ACE inhibitor scintigraphy.
ACE inhibitor scintigraphy. Can you break that down a bit?
Sure. It involves injecting a radioactive tracer and then giving an ACE inhibitor to see how the kidneys respond.
A radioactive tracer, what's that?
It's a special substance that emits a tiny amount of radiation, allowing us to track its movement in the body using a special camera.
You inject it into the bloodstream and it travels to the kidney.
Exactly. And by giving an ACE inhibitor, we can see how the kidneys respond in terms of blood flow and filtration.
So if there's a significant narrowing in the renal artery,
We'll see a difference in how the tracer is taken up by the kidneys.
that's really cool.
It is. In addition to ultrasound and scintigraphy, we have CT angiography and MR angiography.
Those are the ones that use X-rays and magnetic fields.
Yes, they create very detailed images of the blood vessels.
So we can see the location and severity of the narrowing.
Precisely. And then there's conventional arteriography, which is considered the gold standard, but it is the most invasive.
So many different ways to image the renal arteries.
There are. And the choice of test depends on the individual patient and their situation.
Makes sense. So we've covered the diagnostic workup for RAS. Now let's talk treatment. What's the game plan for managing this condition?
The treatment approach depends on the severity of the narrowing and the patient's overall clinical picture. For less severe cases, we might opt for a conservative approach.
Focusing on risk factor control.
Exactly. Managing blood pressure, cholesterol, diabetes, if present, encouraging lifestyle modifications.
Like smoking cessation, a healthy diet and exercise.
All important for slowing the progression of the disease.
It's a reminder that lifestyle modifications are powerful tools in managing cardiovascular disease.
They are. But for more significant stenosis, especially when it's causing renal insufficiency or uncontrolled hypertension, revascularization is often necessary.
Revascularization, meaning opening up that narrowed artery.
Right. And we have two main options, angioplasty and surgery.
Angioplasty is where they use a balloon to widen the artery.
And often place a stent to keep it open.
When is surgery a better option?
Surgery is typically reserved for cases where angioplasty is not feasible or has failed. For example, if the narrowing is very long or complex, or if there's a lot of calcification.
Okay, so the treatment for RAS can range from lifestyle changes to more invasive procedures.
It can.
This is a lot to absorb.
It is.
What are some key points our listeners should focus on for the MCCQE?
For the MCCQE, understanding the connection between RAS and hypertension is key. Knowing the different diagnostic tests, what they tell us, and when to use them is also important.
And being able to differentiate between the conservative management approach and the need for revascularization.
Exactly. It's all about putting the pieces together.
Recognizing the signs and symptoms, knowing how to diagnose it, understanding the treatment options.
And as always, paying attention to those high-yield topics like risk factor modification.
So for our future doctors out there, remember that RAS is often a silent culprit behind resistant hypertension. Be vigilant, know your diagnostic tools, and be prepared to discuss the various treatment options.
Well said. Welcome back to the deep dive, picking up right where we left off.
Back into the world of cardiovascular disease.
Getting you prepped for that MCCQE,
We covered a lot last time. Atherosclerosis, acute coronary syndrome.
renal artery stenosis laid the groundwork.
It's amazing how interconnected these conditions are.
It really is, all stemming from atherosclerosis.
Highlights the importance of a holistic approach.
It does, and that starts with understanding the underlying mechanisms.
So let's dive back into those details.
Mhm.
I'm curious about the different types of ACS.
Okay.
We touched on STEMI and NSTEMI, but can you explain the key differences between them, in a way that makes sense for the MCCQE?
Of course. Both STEMI and NSTEMI involve a blockage of a coronary artery, leading to a decrease in blood flow to the heart muscle.
Okay.
The difference lies in the severity and location of the blockage.
Tell me more about STEMI. What makes it so serious?
STEMI stands for ST elevation myocardial infarction.
Right.
The ST elevation refers to a specific pattern we see on the electrocardiogram, the ECG.
Those ST elevations are like flashing red lights?
Right, signaling a major blockage.
Yeah.
In a STEMI, the blockage typically involves the full thickness of the artery wall,
Wow.
causing a complete interruption of blood flow to a large portion of the heart muscle.
That's why time is of the essence.
It is. The longer the artery remains blocked, the more damage occurs to the heart muscle.
So rapid reperfusion is crucial.
Absolutely, either with PCI or thrombolytics.
So STEMI is a full-blown blockage with those ST elevations on the ECG. What about NSTEMI? How is that different?
And STEMI stands for non-ST elevation myocardial infarction. In this case, the blockage might be partial or involve a smaller artery.
Okay.
So the damage to the heart muscle might be less extensive.
So STEMI is still serious, but maybe not as immediately life-threatening as STEMI.
That's a good way to think about it. While NSTEMI might not have those dramatic ST elevations on the ECG, it still represents a significant disruption of blood flow to the heart muscle.
And it needs to be treated promptly.
Yes.
How do we approach treatment for NSTEMI? Is it the same rush to PCI as with STEMI?
Not necessarily. The treatment for NSTEMI is often a bit more individualized. We'll start with medications to stabilize the patient, relieve pain, and improve blood flow.
Okay, and then?
We'll assess the patient's risk factors and clinical presentation to determine the best course of action.
A more nuanced approach.
Exactly. Some patients with NSTEMI might be candidates for early PCI, while others might benefit from a more conservative approach initially with close monitoring and potential catheterization later on.
This is where clinical judgment comes in.
It does, weighing the risks and benefits of different treatment options for each individual patient.
And don't forget about unstable angina,
Right.
another form of ACS that doesn't involve actual heart muscle damage, but still indicates a significant reduction in blood flow to the heart.
Yes.
It's like the warning sign before heart attack.
You could say that it's characterized by chest pain that occurs at rest or with minimal exertion, and is often more severe or prolonged than stable angina.
A sign that something's not right and the patient needs further evaluation.
Precisely. Now, shifting gears a bit, let's revisit renal artery stenosis.
Okay.
We talked about how it can lead to hypertension and even kidney damage.
I remember you mentioned that atherosclerosis is a common cause of RAS.
It is.
Are there other culprits?
Yes, there's another condition called fibromuscular dysplasia, or FAD, which can also cause RAS.
FMD, I'm not familiar with that one. What is it?
FMD is a condition that affects the arteries in the body, causing them to narrow or bulge. Unlike atherosclerosis, which is characterized by plaque buildup, FMD involves abnormal cell growth in the artery walls.
So it's a different mechanism of narrowing, but the end result is the same reduced blood flow to the kidneys.
Exactly. And while atherosclerosis is more common in older adults, FMD tends to affect younger people, particularly women.
Interesting. So if we see a younger patient, especially a woman, presenting with resistant hypertension, FMD might be higher on our list of suspects.
Exactly. It's one of those clinical pearls. Now let's talk about how we can treat RAS.
Okay, so we've got the conservative approach with lifestyle modifications and medication for less severe cases. What about those situations where we need to be more aggressive? What does revascularization entail for RAS?
For RAS, revascularization can involve either angioplasty or surgery. Angioplasty is typically the first-line approach, and it's similar to the procedure used for treating coronary artery disease.
Using a balloon to open up the narrowed artery and often placing a stent.
Exactly. And for RAS, we have different types of stents to choose from depending on the location and severity of the narrowing.
Different types of stents.
We have balloon expandable stents, which are made of metal mesh and are expanded using a balloon. We also have self-expanding stents, which are made of a flexible material that expands on its own once it's placed in the artery.
How do doctors decide which type of stent is best?
The choice depends on several factors, including the size and location of the narrowing the anatomy of the renal artery and the patient's overall health. Sometimes we even use drug-eluting stents, which are coated with medication that helps prevent the artery from re-narrowing.
Wow, technology has really advanced.
It has.
What about surgery? When is that a better option than angioplasty for RAS?
Surgery is typically reserved for cases where angioplasty is not feasible or has failed. For example, if the narrowing is very long or complex, or if there's a lot of calcification in the artery.
Makes sense. It's a judgment call based on the individual patient.
It is. Now, I know we've covered a lot of technical details.
We really have.
I want to circle back to something really important, the impact of these conditions on patients' lives.
I agree. It's easy to get caught up in the science.
But it's about helping real people.
Imagine the fear when someone has chest pain, wondering if it's a heart attack.
Or the frustration of struggling with uncontrolled hypertension.
Empathy and compassion are so important.
Absolutely. And that brings us to a key takeaway for the MCCQE. You need to be able to connect the dots between the pathophysiology, the clinical presentation, and the impact on the patient.
It's not just about knowing the facts.
It's about understanding the human side of these conditions.
So let's consider the broader implications of what we've learned about cardiovascular disease.
Okay.
What about prevention?
Prevention, the best medicine.
Right.
That's where those modifiable risk factors come in. Things like smoking, high cholesterol, high blood pressure, diabetes, obesity, lack of physical activity.
Things people can change to reduce their risk.
Exactly. It's not just about treating the disease, but also empowering people to take control of their health.
Shifting the focus from reactive care to proactive care.
Exactly. And that's a key message for future doctors preparing for the MCCQE. Don't just focus on the treatment algorithms. Think about the bigger picture. How can we promote healthy lifestyles, screen for risk factors, and intervene early?
It's about thinking beyond the individual patient and considering the health of the community.
It is. Being a champion for public health, raising awareness, working to create a world where heart disease is no longer the leading cause of death.
A powerful vision.
It is. And it's a reminder that the MCCQE is just one step in a lifelong journey.
Of learning, growing, and making a difference.
Well said. Now, before we get too philosophical, let's take a quick break and then come back for the final part of our cardiovascular deep dive.
We're back for the final part of our cardiovascular deep dive.
That's right. We've explored atherosclerosis, acute coronary syndrome, and renal artery stenosis.
We've covered a lot from the cellular level to the impact on patients' lives.
And we even touched on prevention and public health.
I hope our listeners are feeling more prepared for the MCCQE.
Me too. But before we wrap up, let's do a quick review of some key takeaways.
Sounds good. I'm ready.
All right, so atherosclerosis. It's a chronic progressive disease that starts early in life.
With those fatty streaks.
Those fatty streaks can develop into dangerous plaques.
Which can rupture and cause heart attacks or strokes.
Exactly. And we talked about LDL cholesterol inflammation.
All those factors that contribute to plaque formation.
And rupture. Don't forget about the diagnostic tests, too.
Like lipid profiles, blood pressure checks, imaging techniques.
Coronary calcium scoring, angiography, all important.
So that's atherosclerosis in a nutshell. What about acute coronary syndrome? What should our listeners remember for the MCCQE?
With ACS, it's all about recognizing the different presentations.
Typical and atypical.
Right. Chest pain is classic, but not always present.
Especially in women diabetics and older patients.
Exactly. We talked about shortness of breath, nausea, jaw pain.
Symptoms that can be tricky.
They can mimic other conditions.
And ECGs are crucial for diagnosing ACS.
Absolutely. Especially for differentiating between STEMI and NSTEMI.
And knowing those treatment algorithms.
Including rapid reperfusion for STEMI.
So we've got atherosclerosis and ACS covered. What about renal artery stenosis? Any key points for our listeners?
With RAS, remember, it can be a silent culprit behind resistant hypertension.
Right.
Knowing the connection between RAS and the renin-angiotensin-aldosterone system is key.
For understanding how it develops and how to treat it.
Exactly. Remember, those two mechanisms reduced blood flow and the hormonal cascade.
Leading to vasoconstriction and fluid retention.
Right. And don't forget about fibromuscular dysplasia.
As another possible cause of RAS.
Especially in younger patients.
Good point, right? It's important to consider other possibilities.
Absolutely. And remember, the MCCQE is all about applying your knowledge to clinical scenarios.
Thinking critically and putting the pieces together.
Exactly. So as you study these conditions, think about how they might present in a patient, what questions you would ask, what tests you would order.
And how you would interpret the results.
Right. And don't forget about the bigger picture.
Prevention, public health.
Exactly. How can you, as future doctors, advocate for heart health in your communities?
Yeah.
How can you promote preventative measures?
It's not just about treating the disease, it's about preventing it.
Absolutely. Now, before we sign off, I want to leave you with one final thought. The MCCQE can feel daunting. But remember, it's just one step in your journey to becoming a skilled and compassionate physician.
It's a challenge, but also an opportunity to learn and grow.
And you're not alone. You have resources to support you.
Like the deep dive.
Exactly. So keep studying hard, stay curious, and never stop learning.
We're here to cheer you on every step of the way.
Best of luck on your MCCQE journey. We'll see you on the other side.